Welcome back to the Virtual Transplant Journey 2024. Our next session is Know the Risks, an overview of common skin diseases post-transplant. Please remember you can post your questions in the Q&A tab and we will share with the speaker. Dr. Madeline Stump, our next speaker, is currently a transplant cutaneous oncology fellow at Johns Hopkins University School of Medicine. Her clinical interests focus on caring for patients with solid organ transplants and those with complex skin cancer history. Her scientific interests include mechanisms of skin cancer development, particularly in the setting of prolonged immunosuppression. Please welcome Dr. Stump.
Thank you so much. Thank you so much. It's a pleasure being here today. Let me share my screen. Can you see this?
Yes. Yes.
Thank you. All right. So good morning, everyone. It's absolutely a pleasure being here today. Thank you so much for spending your day with us, learning. If you're in Baltimore, it's a great day for learning because it's raining outside. If you're in a warmer climate, well, kudos to you. Before we get started, I want to say a big thank you to all of the transplant patients that I've met this past year. I've learned so much from you. Your resilience inspires me so much to continue taking the transplant care for the dermatologic care for transplant patients to new boundaries and push those boundaries in the field forward. So thank you. So today's talk is structured into 5 different parts. We'll start with the immune system and its role in how it keeps you healthy. We look at your medications and what are the effects they have on the skin. We'll look at some common skin infections for patients that have undergone transplant. We'll also talk majority of the time about skin cancer, and we'll wrap up with recommendations and tips of how to stay healthy and how to prevent skin cancer from forming. After each one of the sections, I'll have an opportunity for you to ask questions. Please do so. This is for you. If you have a question, inevitably, any other participant will also have that one, and we'll all benefit from the answers. We are very fortunate today to have with us one of our dermatology residents at Hopkins, Dr. Leora Eisman, who volunteered her time to field the questions in the Q&A while the presentation is going. So please feel free to ask questions. Okay, so we're going to get started with the immune system and its role in keeping you healthy. So your immune system is a large network of organs, white blood cells, chemicals and proteins, and all these parts work together to fight disease-causing germs, bacteria, viruses, parasites, or fungi. This is something that you guys all know. But what is probably less known is that the immune system also recognizes and neutralizes harmful substances from the environment. And most importantly, those immune cells circulate throughout the blood and detect abnormal, malignant, or cancer cells. So what do all these parts have in common? From the point of view of the immune system, they're all foreign substances. And do you know what else appears foreign to the immune system? That is right. The transplant organs that many of you have received and some of you will receive. So how do we keep the immune system happy and at bay and protect your organs from attack from the immune system? Well, we give you medications appropriately termed as immunosuppressants. And when we do that, though, when we put a brake on the immune system, it no longer can exercise its shielding function. So now patients on those medications are at increased risk for infections, and also importantly, increased risk for cancer, because the detecting functions of the immune system are now suppressed. So this is the first break. Any questions so far?
No.
Nothing. So we'll keep going. Now we'll take a look at the immunosuppressive medications that you are on, patients who have received a transplant, and what effects those have on the skin. Immunosuppressive medications have a lot of side effects. We'll focus on those that pertain mainly for the skin. I have picked 3 main classes of immunosuppressive medications that are most common for the immunosuppressive regimens of most patients. So we'll start with systemic steroids. Systemic steroids are used in many immunosuppressive regimens and often prescribed at high doses early in the post-transplantation period, and they tend to be tapered or even discontinued later on. However, systemic steroids have a lot of side effects, both internal and on the skin. So usually about 50% of patients who have been for 3 months or greater on steroids such as prednisone of 20 milligrams or higher will develop skin manifestations. And some of the most common ones include skin fragility that is manifested as stretch marks, or we call them striae in medical terms, bruising, we call purpura, also acne forms, and cushingoid changes of the skin are seen. These are all due to the fact that steroids will inhibit the synthesis of collagen in the skin, also will decrease the proliferation of fibroblasts. These are cells in the skin that build the connective tissue. And in addition, steroids also suppress the synthesis of elastic fibers, what keeps the skin nice and stretchy. So all these changes taken together will lead to increased skin fragility. And usually that develops about weeks to months after starting steroids. Stretch marks, this is a picture of stretch marks here. Oops, I'm sorry. And it's rather an unusual site to develop those. They mostly will develop on the thighs, the buttock area, the abdomen. They are difficult to treat. Oftentimes they will subside, or even sometimes if they are minor, will resolve with discontinuation of steroids. But sometimes the changes would persist. There are some things that we can do in the office and we can advise patients about, but overall, it's very difficult to reverse that change that happens with suppression of collagen synthesis and elastic fibers. Steroid acne is something that some patients will experience, and it's different from the regular acne in that here, this picture in the middle demonstrates very well. It's characterized by these monomorphic or the same shape and appearance bumps or papules, and also pustules. These are bumps that have pus in them. And in contrast to the regular acne, it doesn't have the big cystic lesions or comedones as well. Tends to develop mostly on the trunk, sometimes on the face. We do have ways that we can treat that in the office. Sometimes we use, depending on the severity, we could use short course of antibiotics, which have anti-inflammatory actions, or topical types of preparations. Finally, cushingoid changes could also occur once patients are on systemic steroids. The good news for those are that tend to resolve or disappear with discontinuation. But this type of skin change is due to redistribution of the fatty tissue and mainly accumulates in the face, leading to formation of the so-called moon-shaped face. The cheeks become rounder. Also, there is a fat deposition in the back of the neck. We call that a buffalo hump, and also the truncal areas as well. So the other very, very common immunosuppressive medication that most patients are on is called tacrolimus. Compared to other immunosuppressive regimen, tacrolimus has relatively few skin-related side effects. One of the interesting and kind of ones that cause more discomfort to patient is hair loss, shedding, or alopecia. This is very interesting. Mechanism not necessarily known. I'm showing you pictures of a study of 59 patients who had a simultaneous kidney and pancreas transplant. There were 29 female patients, the rest were male. 40 patients were on tacrolimus, and the rest of the patients in the study had cyclosporin as their immunosuppressant. 13 or 29% of patients who were on tacrolimus develop excessive hair shedding about 1 to 14 months after the start of tacrolimus. And all of these patients were on tacrolimus. None of the patients on cyclosporin developed the hair shedding. And interestingly, 11 out of the 13 patients were female and 2 only were male. So this is a female predominant type of effect that has been demonstrated in kidney. Kidney transplant, this paper particularly emphasizes kidney and pancreas transplant. We don't know, as I said, the mechanism. The process is known as telogen effluvium, or shifting of the hair cycle from growth phase to shedding, or telogen effluvium phase. It is hypothesized that this is due to the fact that tacrolimus has a vasoconstrictive, or narrowing the blood flow to the scalp and the hair follicles, hence leading to increased hair shedding. And that's supported by the fact that when patients are treated with a topical minoxidil or Rogaine, they respond really well. And one of the thoughts here is that topical minoxidil is vasodilatory, or improves blood flow to the scalp, leading to reversal of those effects with tacrolimus. So I have seen several of those cases. And as I said, just as shown in the paper, they respond very well to the topical treatments. Okay, so moving on to a class of immunosuppressive medications called mTOR inhibitors. These are sirolimus and everolimus. They have a large number of cutaneous or skin-related side effects. I've shown some of those. On the leftmost picture, you see palmar peeling. This is the palmar surface of the hand. It can occur in the feet as well, on the bottom of the feet. It can happen right away after starting sirolimus or months after. It's rather uncomfortable because this excessive peeling can lead to painful erosions and also fissuring of the skin. Interestingly, it may resolve spontaneously even while on the medication, but oftentimes resolves after discontinuation. The middle picture shows, again, acne formation in a patient on sirolimus. The mTOR inhibitors, they affect the so-called pilosebaceous unit, or the hair follicle unit, and that leads to formation of acne. Again, in the office, we have a lot of recommendations that how we can mitigate some of those unpleasant side effects. For me, one of the most serious ones is the delayed wound healing that is often seen in the context of an mTOR inhibitor. You can see on the pictures on the right, on the topmost one, you see a leg ulcer that has not been healing for a long time. This is a rather serious complication, especially in patients who have undergone surgery, because their wounds don't heal. And oftentimes they can have complications such as dehiscence or opening of the wound. So that's common. The other thing that happens with the mTOR class of immunosuppressive medications is swelling of the feet and dependent extremities. The bottom picture here on the right shows you a condition called lymphedema. This is due to blockage of the lymphatic drainage. Sirolimus in particular would affect the formation of lymphatic vessels, so lymphangiogenesis. Therefore, there is a decreased return and absorption of the lymphatic fluid. It's rather, it's a difficult side effect to treat for patients. So these are some of the cutaneous side effects of most common immunosuppressive medications. I see that questions are coming. Don't forget to not put them in the chat, but in the Q&A, anything that I can answer at this point. Let's see. After stopping tacrolimus, does your hair grow back? It actually does grow back. Yes, that is correct. And then another question is, will skin improve if dose of meds are reduced to, say, 5 milligrams on prednisone or lower dose of Tacro? You know, the lower the immunosuppression, yes, the skin symptoms will improve as well. Again, some of those changes, like inhibiting the collagen and elastic fibers, they may be permanent, but at the lower level of immunosuppression, some of the things that we can offer you may actually be more effective in mitigating some of those side effects. So it is always a balance. As a transplant dermatologist, we work closely with your transplant team because the first and foremost role is to protect the organ, and then we can mitigate some of the skin manifestations. The most critical one, as in we'll see and talk about it at kind of toward the end of the talk, is the skin cancer. Okay, these are fantastic questions. Thank you for those. So let's see. Next, we'll talk about some skin infections. This slide will become familiar to us. When we suppress the immune system, we are at increased risk for infections. We talked about anything such as bacteria, viruses, parasites, or fungi is now likely to cause a problem. So what are some of the most common skin infections that we see in patients who have undergone transplantation? Well, we'll talk about infections caused by viruses, and we'll talk about infections caused by fungi. Warts are very common in anyone, actually. They're caused by a ubiquitous or ever-present and always everywhere present virus called HPV. In normal conditions, even in immunocompetent patients, these viruses, the HPV virus is very clever and it tends to hide well in the skin. And so the immune system has a hard time detecting it. Once it does, it can clear it. In immunocompromised patients on medications, that becomes a problem. The warts can become more numerous and more difficult to treat. Even then, we still have a lot of modalities and options in the office that we can treat warts. One of the more serious complications of immunosuppression is shingles or herpes zoster development. Shingles is caused by the varicella virus. This is the same virus that causes chickenpox. You can think of chickenpox as part one to the shingles. So back in the 1990s, they started vaccinating all babies against chickenpox. And since then, you know, the rates of shingles have decreased. However, before the 1990s, people acquired immunity to the virus by being exposed and having the disease. The problem with this particular virus is that it tends to hide, it loves to stay in the nerve roots where close to the spinal cord. And in normal immunocompetent patients, so normal baseline conditions, the immune system will tend to keep it at bay. But when patients develop, are under immunosuppression or have had trauma or have been hospitalized, the immune system is weakened and is no longer able to keep that virus at bay, and so it reactivates. And it travels down the nerves all to a particular area of the skin that's innervated by that nerve. So 20% of immunocompetent patients could develop shingles, but this number increases to 50% in patients who are immunosuppressed. And unfortunately, immunosuppressed patients will have higher rates of complications because this can become disseminated. In addition, this not only has a rash, but after the rash, there's a condition called post-herpetic neuralgia that has its own complications. Combination treatments by us, transplant dermatology, in conjunction with the transplant team, we can offer some mitigation of those symptoms. Another very common thing that happens is athlete's foot or tinea pedis. Many people would have fungus on their feet. Their nails could look like this. Oops. And the fungus can also involve the skin of the feet. A very, very simple, effective, and safe remedy that one could use at home is a part of white vinegar to mixing one part of white vinegar and 1 part of water and soaking the feet for 10-15 minutes a day. The vinegar has really great properties against the fungus and also bacteria. This is an exaggerated, this picture of the fungus can grow on the skin as well. This is rather an involved presentation. Most of the time, even in immunocompromised patients, we see smaller areas of involvement, such as just this. Again, this is diagnosed in the office, and we have both topical and sometimes we'll need to do some oral treatments for this. And we do that in conjunction with the transplant team as well. Okay. So any questions on the skin infections? Again, I will open the Q&A. Let's see. Post-transplant and now Hep B vaccines cause more concerns for the skin. Does this cause Hep B positive? I don't know that it does more. Post-transplant now Hep B positive, not necessarily for the vaccines. Again, you should work really closely with your transplant team and make sure you have all your vaccinations in order to protect against some of those. Have you heard about Tegoprubart, a new immunosuppressive medication? Actually, I'm not familiar with this. This is probably the brand name of it. I wonder if this is a biologic medication. That will be interesting for me to look. I have not heard of it. A lot of oval dry spots. Well, this is something somebody asked about, a lot of oval dry spots on their body. This will be something to bring up to your physician. Somebody's asking if they're now Hep B positive, so will I be more susceptible to the skin virus? Not necessarily. Okay. Thank you, guys. We'll keep moving. Now we're going to talk about the skin cancer in organ transplant recipients. This is a bigger and important part of the presentation. So again, our very familiar slide. We have suppressed our immune system to keep the transplanted organ happy, but now the screening abilities of our immune cells have been significantly reduced to be able to detect malignant or cancer cells. And in fact, cancer of any kind is twice more likely in patients who have undergone solid organ transplantation compared to immunocompetent patients. But more importantly, non-melanoma type of skin cancer is 13 times more likely. So skin cancer is the most common malignancy after transplant. So let's talk a little bit about statistics. And starting with statistics of the general population, patients who can, so this is in immunocompetent patients. 1 in 5 70-year-olds that are born in the US will develop a skin cancer during lifetime. Compared to that, 1 in 2 of white transplant patients are at risk of developing skin cancer. Patients of color, their risk is a little better than that. It's 1 to 6%. They tend to develop skin cancer. However, the good news ends there because non-white transplant patients are more likely to have less frequent dermatologic exams, less skin cancer counseling, and skin cancers are more likely in sun-protected areas. So genital areas, buttock area and bottom of the feet are common places of skin cancer for patients of skin of color because these are less examined areas. Oftentimes, clinicians will not ask for it. Patients also feel self-conscious about talking about this, but this is really important. I can tell you that in the past 9 months, I have seen 3 patients, skin of color patients, who had skin cancers in the genital areas, in the buttock area, and one patient had a melanoma on the bottom of the foot. So very, very important to screen for those and to be aware that they can develop there. The sooner we detect them, the better the chances of treating them and the easier the treatment options are. So let's talk about what do skin cancers look like. Some of them are very, very obvious. Anyone here looking at all these pictures can say, oh yeah, you definitely need to see a clinician. So these are the two of the most common types of skin cancers that can affect transplant patients or also immunocompetent patients. So the top row is two pictures of basal cell carcinomas. There's very many different ways basal cell carcinomas can present. Most commonly, they can have these flesh-colored bumps. You see those squiggly blood vessels on the top. These are very vascular cancers. When they're lightly bumped, they tend to bleed on their own. The key finding here is that they don't heal. Sometimes skin cancers can look like these eroded plaques that just don't heal. On the bottom, you see examples of squamous cell carcinomas. They love the lower lip. And that's unfortunate because the squamous cell, contrary to the basal cell, and we'll talk about it again a little later, they tend to be more aggressive and don't stay in the same place. They to be more invasive. And so as you see the lower lip, there's not much real estate. Standard of care is a surgical excision. This could lead to significant change in the function and aesthetics here of the mouth. So the key is the sooner we detect them, the better the outcomes. I'm showing this the bottom of a foot. This is a squamous cell carcinoma that can develop there. So these are sites that we not often check. Some skin cancers, so those ones were easy. Anyone can diagnose them. But what becomes tricky is those skin cancers that are less obvious. Oftentimes, they're early skin cancers. These slides are courtesy of my mentor, Dr. Manisha Loss. And you can see here, this is not that difficult to see. There's a little brown spot with maybe some scale. I'm not showing you the entire face of the patient, but maybe he has many normal brown spots that are just aging related changes of the skin that this is very difficult to distinguish from. So oftentimes it's hard for patients to tell, is this normal change or is this skin cancer? This is even more difficult for those of you who were able to zone in on this area. Good for you, because that is a very subtle change and underscores the fact that regular skin exams by a dermatologist, and I want to underscore too, a board-certified dermatologist. If you can find a transplant-trained dermatologist, even better. But this will increase your probability of detecting those skin cancers and diagnosing them early, because the outcomes are better and the treatment options we have are much more numerous. So let's talk about the characteristics of the non-melanoma skin cancer and organ transplant recipients. They tend to occur on average of 30 years earlier, okay? So if you think about this, there is a phenomenon of the immune system. With normal aging, it goes through a process called senescence or slowing down. In a sense, this is a natural way of the immune system becoming suppressed with age. But when you immunosuppress artificially through medication a patient, they will develop skin cancers much earlier. In the immunocompetent patients undergoing normal aging process, skin cancers will develop, if they had a significant, sun exposure in the past, they will develop in their 70s, definitely, into the 80s. But solid organ transplant recipients will develop those skin cancers 30 years earlier. These patients tend to have more frequently multiple skin cancers, not just one. And those, unfortunately, skin cancers will be characterized by more rapid rate of growth, increased rate of recurrence, meaning that once you treated it, let's say you had a squamous cell carcinoma on your arm, and that you underwent an excision for it, and it was completely clear, the chances of you having a recurrence at that same spot is much higher compared to an immunocompetent patient or a patient that is not on immunosuppressive medications. In addition, unfortunately, skin cancers have a higher rate of metastases in patients who have undergone a solid organ transplant. And that is why we watch you very, very closely. Okay, so who is most at risk? What are the factors that are unique to transplant patients? Well, three main ones. Age at transplantation. Older means higher risk. Again, I talked about natural immunosuppression. With aging, immune system undergoes senescence. So you have that process that you cannot stop at older age. When you also, on top of that, add immunosuppression by medication, your risk increases significantly. So the older you are at transplant, the higher the risk you have, and the longer, accumulated effects of sun exposure. Times is transplantation. Longer means higher risk. It also makes sense. You have been under immunosuppressive medication for longer. Level of immunosuppression. The higher the levels, the higher the risk. That is why in some patients who have an extensive risk of skin cancer, extensive skin cancer history, we work closely with the transplant team to modify the immunosuppressive regimen. Honestly, I have worked closely with the team to modify an immunosuppressive regimen on a patient with recalcitrant or very difficult to treat warts. The same thing to kind of mitigate some of those effects. Okay, let's now focus on each one of the skin cancers separately. Let's talk about squamous cell carcinoma. I have a lot of respect for squamous cell carcinoma. 65 to 250 times more likely to occur in transplant recipients. That is a very scary statistic. And the reason for that is because this cancer doesn't like to stay where it is. It grows faster, it tends to invade, and it tends to metastasize. Okay, so early detection is absolutely critical here. How do you spot it? A lot of the times, the squamous cell carcinoma will develop from a precancerous lesion called actinic keratosis. When you guys come in the office and you have these red, pink, or brown spots shown here on the bottom picture with this rough, gritty scale, they just don't heal. Those are actinic keratosis. These are the signs of skin damage. There is a change in the DNA in the skin cells there, and they're starting to multiply. So 1 out of 10 of these premalignant lesions could go on and develop into a squamous cell carcinoma. 9 out of 10 may resolve on their own. We in the office don't know which one of those is likely to misbehave, and so we treat all of the premalignant lesions. So again, squamous cell carcinoma loves sun-exposed areas. Look at the hands. Our hands get a lot of sun. And then other sun-exposed, they love lower lips too. Top of ears. It's the one place that patients often forget to apply sunscreen, for instance, is the top of the ears. And if you think about it, both the lips and the ears, as I said before, it's a very expensive and small real estate. So there's not that much, there is a very small area for this tumor to grow, and reconstructions and cure of that is difficult. The next one is the basal cell carcinoma. It's 10 times more common in transplant patient recipients. This is the same picture I showed you before with the kind of a round skin bump with the squiggly blood vessels on it. Sometimes though, basal cells will appear as a scar or a scratch that simply doesn't heal. It can be a shiny bump or patch. Again, also loves sun-exposed areas. Characteristically, it may bleed or crust repeatedly. The key here finding is that it does not heal. And finally, melanoma. Thankfully, the good news for this scary cancer is this the least common in transplant recipients, but it's still more common in immunosuppressed patients than in immunocompetent patients. Oftentimes forms from an irregular brown spot or a changing mole. Here are some pictures of the most common types. We use the acronym ABCDE, which stands it just summarizes the changes that happen with the moles. So diameter changes, there's E stands for evolving mole, color changes. You can see that there's different colors within the mole. The border is irregular, and also A stands for asymmetry, meaning if you draw a line in the middle of the lesion, the two sides are not the same. Most commonly is from, a changing mole, a brown lesion. There are times, however, that, and it's more rare, that melanoma can be amelanotic, meaning does not produce the melanin or the pigment that makes it brown. And those are very tricky to detect. Even for a trained dermatologist, these are scary cancers. And again, constant vigilance and working closely with your physician is the key for prevention here. Okay, this was a bigger section. Questions here? No questions. This, by the way, is how a basal cell carcinoma looks under the microscope when it's been sectioned and stained. It's this very pretty purple islands that it has. So it looks pretty under the slide, but is a very scary thing to see clinically. Okay, so we'll keep going. If no questions, or maybe one question. Will protective clothing help? Thank you, sir. Yes, and we'll absolutely touch on this very shortly. So this section is what can you do to prevent skin cancer from forming? So I think, in order to be able to protect yourself, you need to know what causes skin cancer. And the answer is UV radiation. So ultraviolet radiation comes from the sun. It is arbitrarily divided into 3 different types of rays based on their length. So I'm showing you here penetration of the different types of UV radiation based on the length on the skin here. But UVA, B, and C. Most of the UVC and A is absorbed by the oxygen and ozone layer of the atmosphere. So very little of that will reach the surface of the Earth. However, most of it is UVB. And that's bad news because UVB is the one that will cause skin cancer. UVA, we don't necessarily know its exact contribution on skin cancer formation. As you see here, it penetrates deep beyond the top layer of the skin, which is called the epidermis. It goes into the deeper layers, and it mainly contributes to aging and wrinkle formation. It passes through windows in your car and your office, so you need to know that. Hence, the question about protective clothing, and yes, that's a very useful thing to do. It likely increases the cumulative risk of skin cancer, probably by these changes in the skin. So it, just like the steroids, will decrease collagen formation, will break down elastic tissue. Cancers in general love a really hard matrix, so they like to spread on something that's firm. And so possibly this, and it's not necessarily proven scientifically, but possibly these factors, just general, things that cause aging as well, will increase the risk of forming skin cancers. UVB is the main culprit here. They're shorter rays. That one is the one that causes sunburn and responsible for the formation of most skin cancers. So how can you prevent skin cancer? So here are some general tips. Starting before transplant, you should be evaluated for possible skin cancer. Discuss with your doctor, your dermatologist, what your risk of skin cancer is. This is all based on, history of prior sunburns, blistering sunburns, amount of, sunlight exposure, habits with sun protection, type of skin. Do you burn easily? All of these things will add together to a certain cumulative risk. Be educated and proactive about sun protection and sun avoidance. Examine your skin at least monthly and see your dermatologist regularly for a skin exam. Because if we detect those subtle areas I showed you the subtle skin cancers. They are early cancers. If we can detect pre-cancers or cancers early, this is the best, as we have most types of treatment options available to us at that time. We can also talk about ways of preventing and decreasing, recurrence. The most important thing, however, is aggressive sun protection. That's the best defense against skin cancer. So let's talk about some sun protection basics. What sunscreen should I use is often a question I hear from patients in the office. And we say, find a sunscreen you like. The best sunscreen is the one that you will actually use. How much should I apply? Apply it liberally. It takes 1 to 2 ounces to cover the body adequately, at least 1 teaspoon per body area. And if you think about it, I'll show you some pictures of sunscreens. Most of them are either in a 4-ounce or 8-ounce bottle. So if you think about how much it takes, that one of those bottles should last you for 4 to 8 applications. That's it. So apply it 30 minutes before going out. You need time for it to start working. Repeat applications after swimming and sweating. Optimize the use. Look for sunscreen and daily moisturizer and makeup if you wear that. Be cautious, however, as we recommend SPF, and we'll talk about what that means, in a moisturizer at least 30 or above. Make sunscreen a daily habit. I often tell my patients, my female patients in particular, make that sunscreen be part of your foundation. You come out of the shower and you put it on as a foundation first thing in the morning. Yes, the rule of thumb is to reapply every 2 hours. If you do that, that's wonderful. But if you have that layer from the beginning of the day, that will really get you a long way. UVB peaks from 10 a.m. to 2 p.m. Be cognizant of that and avoid that time of the day. Interestingly, the sand, if you're on the beach, reflects 10 to 15% of UV radiation. So that increases exposure as well. Absolutely no tanning beds. I think everyone understands this. Did you know that people apply only 25 to 50% of the amount used in testing for SPF ratings? That's right. So it requires 1 to 2 ounces to cover the entire body. As I said, 1 4-ounce bottle, that's it. 2 times to 4 times at the most. Okay, so now we'll go over some more sunscreen basics. It's not something that everybody knows, so I think this might be helpful. The suncancer.org website has extensive and extremely helpful information. I really recommend, if you guys have questions and you're looking for recommendations, they are a fantastic source. So what does broad spectrum mean? Broad spectrum means that there's protection against both UVA and UVB type of radiation. Sun protection factor, or SPF, measures how long a person can be exposed to the sun before UVB rays start to burn the skin. So is it 30 minutes? What does that 30 number mean? It means that you are 30 times, it allows you 30 times longer to be under the sun when you have the sunscreen on versus without the sunscreen. So the other important thing to pay attention to is also water resistant or sweat resistant label. Sunscreens may remain effective for either the 40 or 80 minutes. That will be reflected here on the bottle when swimming or sweating. After the time it expires, the sunscreen is no longer protecting you. You need to reapply. Skin Cancer Foundation seal of recommendation. A lot of the sunscreens will have that. They kind of divide their recommendation into the daily use seal versus active seal. The daily use seal is for just if you're walking to your car to go to the grocery store or the mailbox. Active seal is if you're actually exercising and gardening or exercising outside. So you have to look for those seals and apply the appropriate sunscreen. And finally, there are the importance here of active ingredients. There's 2 types of ingredients that comprise a sunscreen. They're chemical and physical blockers. So we'll take a look at those on this slide. So as we said, there's two types of ingredients. There's a long list here of organic agents or chemical ingredients. They have complicated chemical names, and they act as by absorbing UV like a sponge. They reduce the penetration of it into the skin, okay? But if you think about it, they absorb it and then they break down. So that is why reapplication every 2 hours is critical here, because they simply don't work. Also, looking very closely on this table, you can notice that a lot of these only cover either UVB or UVA. Only this one has protection against UVA, which is divided into two different parts, UVA 1 and 2, and UVB. Okay, looking here at this example label of an example sunscreen, you can see this has avobenzone and then homosalate and octinoxate. All of these here chemicals, they're UVA and then UVB coverage. So they have a good broad spectrum here. Okay, so now you know how to read the label. Inorganic agents or physical or mineral blockers are only two kinds. There's titanium dioxide and zinc oxide. They act like a shield. They deflect UV like a shield. They don't absorb the UV light, they just deflect it. So zinc oxide is what is found in diaper paste. That's why it gives it this white color. But if you look at here, both of these compounds cover against UVA and UVB. So the really good broad spectrum coverage with both of these. According to the FDA, only zinc oxide and titanium dioxide ingredients of the physical or mineral sunscreens achieve what is called a GRACE status, or generally recognized as safe and effective. So there, you might have heard, there is a lot of talk about, are the chemical ingredients safe? FDA issued a report in 2021 where they have evaluated all of the possible chemicals that could go into the sunscreens and have only deemed these two, the zinc oxide or titanium and titanium dioxide, as safe and effective. The other ones, the report is not concluded yet. Further investigations are pending. FDA has not said that they are not to be used. It allows the use of those compounds in sunscreens, but only for your information, these mineral-based ones are considered safe and effective. They also lead to less irritation of the skin and usually best tolerated. Okay, so here are some examples of sunscreens. I'm putting that big jug of sunscreen because, as I told you, you need at least 1 to 2 ounces to cover the body. And you basically need to invest in something like this if you're going to be a regular sunscreen user. This is ones that I personally use at home with my family. And we go through these little bottles. This is an 8-ounce bottle. Yeah, multiple of those per a month. These are examples of tinted sunscreens. No one wants to put sunscreen and look like a ghost with a white sheen. And so these sunscreens contain iron, and it allows to have this tinted, to become tinted and blend with your skin. And so you can find multiple products like this. That's why I said you can use it as a foundation, because it will really blend with your skin color. And I mostly recommend these for the face because they're in small compounds, and the rest, it can be very well tolerated, the rest of them for the body. There's some time of the year, my mentor loves to say that sunscreens do expire, and indeed check your bottle label, because I told you the chemical ones, they do have a limited shelf life. When they absorb, they break down, and so they can also break down under just general storage conditions. So you need to check the expiration date on your bottle. Okay, someone asked a very relevant question of sun protective clothing. Yes, I love sun protective clothing. Instead of SPF, they use UPF, or ultraviolet protection factor, as a standard to measure the sunburn protection of fabrics. These are wonderful because You don't have to reapply it. Once you put it on, it won't wear off. It's not messy, oily, or greasy. There's nothing worse than sunscreen all over your car doors and seats. It's non-allergenic and also economical because they last for multiple sessions. Here is an example of one of those sun shirts. These are examples of companies that will produce these types of clothing. I find them really very helpful. So common misconception is that a favorite worn-in white t-shirt or see-through fabric will be protective. That is not the case. Okay, they will not protect you. You will burn and you have increased risk to develop a skin cancer. Okay, so let's review about staying safe in the sun. Sun avoidance is the most effective way to protect your skin from the sun. Avoid the peak times when UVB is present, and that's 12 a.m. to 2 p.m. Sun protective clothing, use that, provides immediate and long-lasting protection. Shirts and hats, sunscreens are very important. The rule of thumb is SPF of 30 or above, broad spectrum, water resistant. Which one should you use? Pick one and use it. That's the most important thing, is the one you use is the sunscreen that will work. Okay, and then how to do self skin exams. Really, really important. What do you look for? You look for new growing or changing bumps or moles, areas that bleed on their own or don't heal in 4 weeks or less, or 4 weeks or more. Examine your body in a full-length mirror. That's very helpful. You always have to look at underarms, forearms, and palms. These pictures are from the American Academy of Dermatology, extremely helpful resource to teach you how to do this. Always look at the legs, toes, soles of feet. We talked about this, how skin cancers can hide in those areas simply because we don't look for them. A hand mirror can be very helpful to examine the neck and the scalp, and also the back and the buttock. Do not forget the genital areas. This is really important. I've told you about patients who have the skin cancers in those areas, and if we detect them early, we have really good ways to treat them. We're coming to the end, but I'll leave you with several take-home messages. No one should die from skin cancer. It is a preventable skin disease. You have the power to decrease your risk of skin cancer. Use sun protection. You have the power to detect skin cancer before they become dangerous. Practice self-skin exams. Okay, before I open it again for last set of questions, I want to acknowledge my mentors this year that made this time extremely formative for me, Doctors Manisha Loss and Kristen Bybee. I also want to extend a huge thanks to Dr. Evan Lipson and the whole medical oncology, melanoma, and skin cancer program here at Hopkins. We were very fortunate to have Leora field some of the Q&A questions that was streaming in. Thank you so much. She is one of our second-year dermatology residents at Hopkins. Last set of questions. And thank you, guys.
Thank you so much, Dr. Stump. That was fantastic. And I believe Leora has answered all of the questions we received. Yes, she has.
Good for I mean, that's a star resident. That's what we expect. Thank you, Leora, so much.
My pleasure. Amazing presentation, Madeline.
Thank you, guys.
Yes, thank you all. We appreciate you being here. Dr. Stump, thank you so much for taking the time this morning to share your insights with us. It was extremely helpful. And I want to remind everyone we have one more set of sessions that start at 11:45, and you can access those Zoom links through the Eventbrite site. And again, thank you, Madeline. Thank you, Leora, and we'll see everyone at the next session.